Mikhail, thank you very much for joining us today.
My pleasure. Thanks for inviting me, Brian.
The topic today we're talking about is the new ICU Intensive Glucose Control Order Set. This is an initiative that the Critical Care Evidence-Based Practice team has been working on to push out through our health system hospitals to take us to the next level of glucose control in the ICUs. There's a few things that we want to learn about this order set today. Mikhail is the physician champion for it, and we also want to hear a little bit about the development of this type of order set and how we can use it best. We also want to know the evidence behind it, and Mikhail is prepared to talk to us about that today as well. So let's just get started. Mikhail, one of the things that I know that you have discussed with me, and I'd like you to tell us a little bit about, is this issue between a static insulin drip protocol versus a dynamic. And if you can kind of take us through historically the difference between those, and maybe even some of the data that you can share with us on that, I'd appreciate it.
Absolutely. So initially, when the order sets were developed to control glucose in intensive care unit, the early protocols typically would be what we call static protocols. And what those are is that the way they work is to look at what the glucose value is right now at a particular point in time, and to give a prescription of how much insulin to administer based on what the glucose is at that particular time point. Those protocols work reasonably well, but one of the problems is, of course, and that's what I think people realized quickly, is that there is a big difference depending on what the glucose was previously, let's say an hour before this particular glucose level was measured. For example, if the glucose is 200 right now, there is a big difference depending on whether it was 300 an hour ago or whether it was 100 an hour ago. If it was 300 an hour ago, obviously glucose is falling very rapidly, and you may change how much insulin you administer based on that. If the glucose was 100 an hour ago, the glucose is rising very rapidly, and you can actually make additional adjustments on how much insulin you're going to prescribe and how you're going to change the drip rate depending on the direction of change in glucose.
So I hear you talk about both the direction, which way the glucose is going, as well as how fast it's going.
Right, the direction, how fast, and the other factor that sometimes is and sometimes is not accounted for in static protocols is patient's insulin sensitivity, so as far as how much insulin the patient actually getting per hour. Of course, the magnitude of change should depend not just on how fast glucose is changing and in which direction it's going, but also how much insulin patients actually requiring. Because a 2-unit change, for example, means something different for somebody who's getting 4 units an hour versus somebody who's getting 15 units an hour in terms of relative percentage or proportion of change in insulin rate. So that's really the gist of it. The really good dynamic protocols account for all of those things. They account for in which direction the glucose is going, how fast it's changing, what is the glucose level right now, and also how much insulin the patient is receiving. What the literature seems to suggest, even though I'll be upfront to say that there is no large randomized clinical trials that compare static versus dynamic protocols in ICU patients, but certainly the experience across medical centers, when you look at all the studies that have been published, seems to suggest that when you use dynamic protocols, you improve glucose control, you have better glucose control compared to static protocol, and you actually tend to have less fluctuations in glucose or glucose variability, and you may have less hypoglycemia, so they seem to be more effective and more safe. But again, most of these are single center experiences, and there is no large randomized clinical trial comparing the two. Having said that, I can tell you that in our own center, when we started using our dynamic protocol and worked on kind of developing and implementing it with our endocrinology group and Mitch Hamburg specifically, we actually did a nursing survey of what the nursing experience is like using the older protocol initially, which was more of a static protocol. And then after implementation of our new dynamic protocol at the time in 2006, to see what the experience was with that. And what we found was that with the static protocol, nurses found that it wasn't quite working the way that they liked, and so they ended up going outside of the protocol and doing a lot of their own adjustments, which can have its own set of problems. And the satisfaction of the protocol wasn't great, and it improved substantially in their experience and their perception of how well patients' glucose was controlled and how often they had to go outside of the protocol to make their own adjustments has actually improved quite a bit with the dynamic protocol. They felt that it controlled patients' glucose better, was safe, and very infrequently did they feel like they had to do something outside of a protocol. And overall satisfaction improved.
Mikhail, you mentioned that you've been working on this order set with Mitch Hamburg, one of our system endocrinologists. One of the things that I'm sure that some of the people here are wondering, why is a cardiologist talking about this? How did you get to this part of this being a major portion of your research, and kind of what's your background? I know you came from Yale, you're a Robert Wood Johnson scholar, but kind of tell us about how you got involved with the whole issue of dynamic protocols at Yale.
All right, so it kind of goes back to about 2004 when I was back at Yale, and during my time as a cardiology fellow and then a clinical research fellow in the Robert Wood Johnson Clinical Scholars Program, we had a large database of acute MI patients, and what we noticed, actually, what I noticed in clinical practice, but also what others around the country were noticing at the time, is that it's a very common issue to have elevated blood glucose at the time of acute myocardial infarction. And even more interestingly, it frequently occurred in people who didn't have any prior history of diabetes. And what we were curious about is whether it's just a kind of stress response, or why do people have high glucose, and does it have any prognostic implications? And so we did a study actually that was published in Circulation in 2005. Was one of the largest studies to show that there is a very strong correlation between elevated glucose levels and mortality in acute MI. Patients with higher glucose were much more likely to die, both within 30 days and within 1 year after having acute MI. And then the big question then, of course, became, is that something that we should intervene on? And that continues to be a very hot debate in cardiology, actually, whether glucose levels should be controlled with intravenous insulin, or whether it's just a stress response. We still don't have a definite answer, and hopefully we're actually working on putting together a series of studies, including randomized clinical trials, to hopefully answer that question definitively. But we've done a lot of additional work since then, since I came to the Heart Institute, including this study over here, where we actually looked at the relationship between average glucose levels and mortality in acute MI, and showed that there is a very nice J-shaped curve relationship with the patients who have glucose within normal range, roughly between 90 and 130 milligrams per deciliter, having the lowest mortality, and as the glucose goes up, patients' mortality increases, and also in the hypoglycemic range, patients' mortality increases. So there is a relatively narrow range where the patient outcomes are optimal. Now again, that doesn't mean that if you actively intervene and keep those glucose levels in that range that you actually improve patient outcomes. That remains to be determined. But it was certainly a very interesting observation that then brought me to work with Silvio Inzucchi. Yeah, Silvio Inzucchi, who actually developed the original Yale protocol right around the time when I was at Yale, and that was published in Diabetes Care right around, I believe, 2005. And in that was the first experience with dynamic protocol in the medical ICU patients, showing that it was very effective in controlling glucose and very safe. When I came here, I wanted to adapt that protocol because I worked with Silvio on several projects together when I was at Yale, and one of the goals I had was to try to adopt that protocol that was developed in the medical ICU for cardiac ICU, and actually implement it in acute MI patients, which is what we did starting in 2006. And we did several relatively small modifications to the original Yale protocol, including what you will see in the order set, which is for the patients who are eating, for example, we administered subcutaneous insulin at mealtime, in addition to intravenous insulin infusion. And the reason for that was because in the cardiac ICU, in our patient population, most of them actually do pretty well shortly after their intervention and are eating normal meals, typically within 24 hours of presentation, where in medical and surgical ICUs, patients can be on intravenous or intravenous nutrition or receiving tube nutrition for a long period of time. In our ICUs, that's very uncommon. So we wanted to account for those mealtime excursions in blood glucose, and that was one of the modifications we made to the protocol. We've since, in 2006, when we started, we've since accumulated really 5 years of experience, now over 5 years, 5.5 years of experience with IV insulin in acute MI population, probably one of the largest in the country. And we just looked at our data again, and it looks very favorable. And as you will see, all the data that we show, this is kind of one of our earlier experiences with a small number of patients, but now that we looked at our 5 years worth of data, it looks very similar, which is that we control glucose very nicely with this dynamic protocol called Yale Mid-American Heart Institute protocol, because it was kind of a joint effort between two institutions. And I don't have the hypoglycemia rate here on the slide, but when we look at it again, we see that the rate of severe hypoglycemia, which is blood glucose of less than 40 milligrams per deciliter, typically the definition used in clinical trials, is less than 0.5%. And that's actually about 0.5% on a patient level, not just the percent of measurements, but the percent of patients that develop it. When you look at any hypoglycemia, the number is a little higher, but we haven't seen any dangerous or life-threatening hypoglycemia in 5.5 years that we've been doing this. So I think our results are very favorable, and in general, the nursing experience has been very positive as well.
On the hypoglycemia issue, did you have that to compare with the old static insulin protocol and the rate of hypoglycemia there?
Yeah, unfortunately, there was no data tracking up to that point, so we don't know. But what I can tell you is, when we compare our rate of severe hypoglycemia to what's seen in clinical trials, it's dramatically lower. So in clinical trials, including in NICE Sugar, that was recently published, you're talking about 10 times the rate of severe hypoglycemia that was observed in those clinical trials compared to what we see in our institution.
That's interesting. Thank you. Well, at this point, let's take a look at the actual order set, and if you'll kind of walk us through what's expected of the nurse and the physician on this order set. Right. What are the key elements that the physician has to make some decisions on here, and how will the nurse be using it?
Right, so the really important point I think to make about this protocol is that it does not mandate anyone to use IV insulin in any patient. It really is a choice of a physician to make a decision whether they want to use IV insulin for glucose control or not. The other small disclaimer that I will make is that this protocol is not intended to be used in patients with diabetic ketoacidosis. And there is a separate order set actually that should be used in people with DKA. This is really for people with significant to severe hyperglycemia, but not a DKA or what we call HHMK or hyperosmolar ketotic state. So those are separate. But in patients with significant severe hyperglycemia in the ICU environment, this is what we would recommend to use. If a physician makes that decision, that's a protocol that would be implemented. The first step always should be to actually check the patient's glucose. And the way that this would work is that when a patient's glucose is checked, if a nurse would then inform the physician what the glucose is, the physician can make a decision whether to implement it. Once that decision is made, the nurse will actually make a determination of where the patient belongs. If the patient has moderately elevated glucose levels that do not cross a threshold about 180 milligrams per deciliter, then it'll just be monitored, and the patient will be screened for either glucose control with hemoglobin A1C if they have known diabetes, or if they don't have known diabetes, they will still have a fasting glucose and hemoglobin A1C assessment to see if they may potentially have either glucose intolerance, impaired fasting glucose, or undiagnosed diabetes. If their blood glucose is above 180 milligram per deciliter threshold, then there will be serious things that will take place, including initiation of intravenous insulin. Now, the things that will happen at that point is that there is actually a calculator that will suggest to the nurse how much insulin to initially administer. And that calculator is right here. It actually tells you what to do depending on what the blood glucose is and gives specific examples. of how you actually calculate the initial insulin bolus rate, bolus dose. As far as the maintenance of IV insulin infusion, that kind of depends on several things, as we've talked about before. What is the glucose now? Which way is the glucose going? And how much insulin is the patient actually receiving? So as an example, let's say patient's glucose is 140 milligrams per deciliter, and it was 90 milligrams per deciliter or 89 milligrams per deciliter an hour before. So that would mean that it increased by about 51 milligrams per deciliter in the past hour. So we would be in this column over here. And the nurse would recognize that it's rising by more than 50 milligrams per deciliter per hour. And then the subsequent instruction would be to increase the insulin infusion by 2 delta. Then the nurse has to figure out what the delta is. And for that, she will go to this table over here and see how much insulin the patient is actually getting. So let's say the patient is getting less than 3 units per hour. So 1 delta would be 0.5, 2 delta would be 1 unit per hour. And so then the nurse would increase the insulin infusion by 1 unit per hour. And so on and so forth every hour. It also gives instructions on what to do if the patient is eating, what to do around mealtime, and then of course hypoglycemia management in case the patient develops hypoglycemic event.
Talk a little bit more about the transition then, if a patient is eating, if the blood sugar is controlled, transitioning the patient from this order set onto subcutaneous Lantus.
So in terms of transitioning, there are a couple of reasons somebody may need to do that. First, if the patient is stable, their blood glucose has been well controlled, they're eating normal meals, but they still require ICU level care for one reason or another, that may be a good time to transition into subcutaneous insulin. The other is if the patient needs to actually be transferred to a regular step-down unit or floor, where IV insulin infusion typically is not used. So when that needs to be done, you calculate the insulin requirements of the past 24 hours, essentially how many units did the patient receive in the past 24 hours, and that can be divided into a basal insulin that can be administered once a day, such as Glargine, or a different kind of basal insulin. And then the rest can be divided into boluses that can be given at mealtime. And of course, the correction insulin be administered depending on what the blood glucose levels are. That can be provided, or if the physicians decide that the patient's glucose control is complicated enough that it needs to be managed by our endocrinology colleagues, that they can do more of a customized approach on a patient-by-patient basis.
And it's probably a good time just to point people towards the basal bolus order set that's available. Mikhail, leading into the last portion of our discussion, I'd like you to take me through perhaps some of the other studies that are out there about this type of order set.
Right, so I think, I'll again point out, I think, an important issue, which is we advocate using this protocol only if a physician makes a decision that this is necessary. This does not mandate the use of protocol automatically in any patient. But whenever we talk about glucose control in ICU, I think it's important to point out that there is some controversy, and in fact, recent clinical guidelines reflect that controversy in light of some of the new studies that have been published. As many in the audience probably will recall, in 2001, this whole field was energized when the original Leuven study from Belgium was published with Griet Vandenberg being the senior author on this study, where in a randomized clinical trial experiment, patients in the surgical ICU were randomly assigned to use intensive glucose control with very aggressive glucose targets versus conventional treatment, which at that time meant mostly leaving glucose alone and not really doing much about it. And in that kind of an environment, in a single center study, there was a dramatic benefit of intensive glucose control with marked 42% reduction in mortality in the ICU and 34% reduction in mortality in hospital. In addition, several other major complications of ICU stay, such as ventilatory requirements and renal failure, were reduced as well with intensive glucose control. There are several subsequent trials, the results of which actually were not completely consistent with the original Leuven study. So the same group from Leuven, Belgium, subsequently published a medical ICU clinical trial, which showed that there was no mortality benefit, unlike in the surgical ICU, but there was a morbidity benefit in terms of ICU level complications. And then several other groups tried to replicate the results and in different environments in the multi-center clinical trials in different types of ICU patients and did not see nearly as much of a benefit. This culminated with the largest randomized clinical trial that was published in 2009 called NICE-SUGAR, and that was led by investigators in Australia, but it was an international multi-center clinical trial that randomly assigned people to two groups. And one was intensive glucose control with aggressive glucose targets, and the other one was conventional glucose control. Now I have to say that unlike in the original Leuven study, the conventional glucose control group in NICE-SUGAR was very different, because at that point we're 8 years later, and conventional glucose control was not kind of ignoring glucose and not doing much about it at all anymore. It was actually pretty good glucose control. So if you in fact look at how patients were treated in the conventional arm of NICE-SUGAR, about 69% of those patients received IV insulin infusion. And the average glucose in that group was about 144 milligrams per deciliter, which we would normally consider actually quite good glucose control. So that was very, very different from original Leuven study, where glucose levels were closer to 200 milligrams per deciliter in the conventional group, and very few patients received IV insulin infusion in conventional group. So the field has moved quite a bit between the first Leuven study in 2001 and NICE-SUGAR in 2009. And that's a very, very important point. So what NICE-SUGAR compared was really aggressive glucose control versus moderate glucose control, where in Leuven, original Leuven study, it was aggressive glucose control versus doing pretty much nothing or very little. And what NICE-SUGAR showed was, in fact, survival was better in patients who received moderate degree of glucose control or more conservative glucose control compared to very aggressive glucose control. And so following this, professional societies actually have made some changes in what they recommend. And what you will see here is that here's the recommendations are to actually start treating patients at a threshold about 180 milligrams per deciliter, which is exactly what our protocol recommends as well. And then to treatment target-wise, the recommendations are to either have a treatment target of 140 to 180, but it's also okay to have treatment target about 110 to 140. Our target is about 100 to 140, and what we've actually found is that it works really well in our institution with very good results and minimal hypoglycemia. And in fact, if you look at the American Diabetes Association and American Association of Clinical Endocrinologists document, they will say that if the institution has a lot of experience in doing this and has had good results, that it's fine to have slightly lower glucose targets, again, this range of about 110 to 140, as long as there is data to support it, and our local data is quite supportive, again, showing very good results in minimal hypoglycemia, much lower than either in Leuven studies or NICE-SUGAR as far as the severe hypoglycemia rates. Ours is much. Do treat if it's over 180, but don't go really, really aggressive. Don't try to get glucose levels below 100 or below 90, which some were trying to do in earlier days, to be super aggressive. So I guess the lesson being that good glucose control is good enough. You don't have to become kind of a zealot and try to bring glucose levels really low, because that's when the hypoglycemia rates go up and even potentially cause harm to patients, which of course nobody wants to do.
So this bottom bar down here is talking about the targets, and it's not recommended to have a target over 180. It is recommended 140 to 180. Acceptable is 110, 140 when your institution has good data to support it.
Exactly.
And not recommended to try to go any lower than that.
Right, and that's pretty much where we are. We are right in that, I would say, acceptable range, and particularly given our experience, I think this is the best way to go at this point. I do think it's important to point out that the reason that the guidelines do not recommend leaving glucose alone if it goes above 180 is because there is really good data to suggest that when glucose becomes really high, that can cause problems for the patients in ICU, including infectious complications in particular. And that's the reason we actually do this.
And in your field, increased mortality from myocardial infarction.
That's right. So certainly levels over 180 are associated with increased risk of mortality and complications in acute MI. Again, in acute MI, we don't have nearly as many clinical trials, hopefully something that will change in the future. We don't have as many clinical trials to guide us as we have in the ICU population, using the trials that I've described.
And just looking at our own data from our own institutions, I think there's a real opportunity here to move this order set out into the St. Luke's Health System. We're looking at the St. Luke's East Lee Summit, St. Luke's Northland Berry Road, St. Luke's South, and even at some of our critical access hospitals that have ICUs that the EICU doctor helps manage with you. These type of order sets, the static order set currently is used fairly significantly each quarter, and so there's an opportunity here for us to, as I said, move to the next level of glucose management. Mikhail, I really appreciate all the work and time you put into this. Mikhail has been our physician champion for this order set and is also willing to meet with physicians and nursing groups across our health system as we make this change to help people know exactly how these are supposed to be used, how to use them optimally. And if there's any discomfort, he would be also willing to field your questions about the order set. Mikhail, thanks for taking time to